Very interesting topic in the renal pathology is the kidney tumors, renal cell carcinomas. So, surprisingly, the hypertension, the obesity, smoking are said to be very important risk factor for the renal cell carcinomas. Not only these environmental factors, most importantly, it is the genetic factors. So, there are so many genes that will get mutated and causes the renal cell carcinomas. Most importantly, we usually ask in the exams, what is the origin of the renal cell carcinoma? Say, clear cell carcinoma, what is the origin? What is the origin of the chromophobeRCCs? Then the collecting duct carcinoma. So, many students will not answer for these questions. So, let us have a look, what is the cell of origin of these renal cell carcinomas? That is more important from pathology point of view. I will go in detail about the pathogenesis of these renal cell carcinomas, and I will begin with the classification of the kidney tumors. The kidney tumors have been classified mainly as two categories, benign and malignant. Rarely there can be metastatic deposits of various tumors to the kidney. It's rare as such. Yes, in benign tumors we have renal papillary adenomas, renal fibromas. They are rare as such. Very common is again angiomyolipoma, combination of the angio, that is vessel component, myo, smooth muscle component, lipoma, that is lipid component. So it's a mixture of the three components in the kidney tumor as such. It is benign, but it is said to be sometimes multifocal in origin, and the proportion of angio component, myo component, lipoma component varies from case to case. So this is one of the interesting benign tumor as such for a pathologist. Oncocytoma is the one which poses a difficulty in differentiating a type of renal cell carcinoma known as chromophobeRCC. So you have to remember, both will look same. Oncocytoma is a benign tumor, chromophobeRCC is a malignant tumor, but microscopically they have so many clinical same microscopy appearance. They will have a eosinophilic granular cytoplasm, so both in oncocytoma and chromophobeRCC, and that is the interesting point about oncocytoma. So let us have in detail a look about the very important tumor, that is renal cell carcinoma in adults, and in children it is the Wilms tumor. My friends, remember the alternate names for renal cell carcinoma. Initially it was described first time by Graves, so we call it as also Graves tumor, and he described it as it is arising from the upper portion of the kidney, and he coined the term hypernephroma. So that's the name, the old name for the kidney tumors. And histologically it is nothing but adenocarcinoma because it is arising from the tubular epithelium. So that's why That's why histologically speaking it is adenocarcinoma of the kidney. Most of these tumors will have a clear cytoplasm, so we also use the word clear cell carcinoma. But remember, all are one and the same. They are the alternate names for the renal cell carcinoma. They constitute around 3% of the visceral cancers, very common in the elderly people, 6th and 7th decade of life. Males, it is more common as compared to females. So remember the histogenesis of the renal cell carcinoma, it is the tubular epithelium. Which tubules? So have a look at this diagram. So don't think that the tumors will arise from the glomeruli. There are no tumors arises from the glomeruli. So it is mainly the tubular epithelium. So proximal convoluted tubule, that epithelium. Normally it is a low cuboidal epithelium with a good amount of cytoplasm, granular eosinophilic cytoplasm. That will give rise to the clear cell renal cell carcinoma. And the distal convoluted tubule is the one which will give rise to the papillary renal cell carcinoma. That is the one which you have to remember two things. PCT for clear cell, DCT for the papillary RCC. Right? Then we have a cortical collecting ducts and medullary collecting ducts. The cortical collecting ducts will give rise to the very peculiar type of renal cell carcinoma, what we call it as chromophobeRCC. So we will see details about these all types of renal cell carcinoma in the next presentation. So medullary collecting ducts, they will give rise to the collecting duct carcinomas. Understood? So this is mainly tubular epithelium which will give rise to the kidney tumors. So the histogenesis is mainly by the tubular epithelium, PCT, DCT and the collecting duct tubular epithelium. What are the risk factors? Smokers have the almost double incidence of the renal cell carcinoma. So smoking habit is said to be the very important factor for renal cell carcinomas, and we have seen most of the RCC patients are smokers. Probably there is a role of hyperestrogenic status, obesity, and hypertension. We don't know exactly how they contribute for renal cell carcinoma. That's why there is a query mark is here, and we have seen the higher incidences in the women and the patient who are on estrogenic therapy and patient who are on uncontrolled hypertension. Certain petroleum products and even heavy metals used and even exposure to asbestosis can also cause the increased incidence of the renal cell carcinomas. Patients who are having dialysis mainly for their chronic renal failure and even acquired cystic diseases, they can also predispose us for the onset of renal cell carcinomas. One of the genetic conditions called as tuberous sclerosis can again have it imposes the risk of development of the renal cell carcinomas. But not only that, it is all genetics. Remember, the renal cell carcinomas, there is a plenty of role for the genes to play. Most important syndrome you have to remember, it is the von Hippel-Lindau gene. That is a gene which is tumor suppressor gene that is get detected in the renal cell carcinoma patients. So we call this as syndrome, von Hippel-Lindau syndrome, which consisted of the renal cell carcinomas. There can be renal cyst will be there, often sometimes bilateral, and these patients can also have hemangioblastomas of the cerebellum and even over the retina. So remember, it's a von Hippel-Lindau gene that's get detected, mutated most of the time. That is a tumor suppressor gene. And we have a familial clear cell carcinomas mainly due to the von Hippel-Lindau gene mutations, and hereditary papillary carcinomas mainly due to the MET gene mutations. So have a look at this thing. It can be sporadic or it can be hereditary. Most of the sporadic papillary carcinomas, they are seen in the upper pole of the kidney, unifocal, only one tumor lesion. So they are mainly due to the trisomies. Trisomy 7, trisomy 16, trisomy 17 can give rise to the sporadic papillary renal cell carcinomas. Loss of Y chromosome and even MET oncogene activation and even PRCC can be get activated with the translocation X:1. So all these will contribute for the development of the sporadic papillary renal cell carcinomas. Whereas hereditary papillary renal cell carcinomas are mainly described in the trisomy 7, and it could be also due to the mutation of the MET. The clear cell carcinomas, clear cell renal cell carcinomas again can be sporadic or it could be hereditary. Both of them are due to the translocation. See the gene that is involved here, translocated, it is a third chromosome. So deletion or the translocation involving the third chromosome is the important factor that causes the renal cell carcinoma. Either 3:6, 3:8, 3:11 translocation can give rise to the clear cell carcinoma of the kidney. Von Hippel-Lindau gene can be again either lost or it can be mutated, or sometimes it could be hypermethylation of this gene can give rise to the renal cell carcinomas. So remember those various syndromes and genetic mutations, that is more important. Histological types of renal cell carcinomas, you have to remember all these histological subtypes of the RCC. Very common is the clear cell renal cell carcinomas. Rarely we come across the papillary renal cell carcinomas. Sometimes clear cell can have even the associated papillary renal cell carcinoma. Sometimes dual things can be seen. More interesting point is the, again, a peculiar type is the chromophobeRCC, and rarely we will come across the collecting duct renal cell carcinoma. So whenever you use the word renal cell carcinoma, we always think about clear cell renal cell carcinoma because that is the one which is very, very common. So almost it goes as a synonym. So renal cell carcinoma, we always think first about clear cell variant. So around 80% of the cases are clear cell renal cell carcinomas. So why the word clear cell? It's all because of the cytological appearance. The cytoplasm is totally clear or granular cytoplasm, and the clear cytoplasm will be positive for the periodic acid shift stain, PA stain, because it contains the glycogen. It also contains the lipid. That's why even it is positive for the lipid. So both glycogen and lipid will be there. So PA is also positive, and IL red O also positive in these clear cell renal cell carcinomas. 95% of these cases are sporadic, 5% are familial, and all these due to the von Hippel-Lindau gene mutations. And 98% of the cases will have unbalanced translocation involving the third chromosome. Either it could be 3:6, 3:8, or even 3:11. Yes, have a classical appearance of the renal cell carcinomas. I told the upper pole is more common, but even lower pole also can be affected. Middle portion of the also can be get affected. But this is a classical appearance of the renal cell carcinoma. It is so called as variegated appearance of the renal cell carcinomas. Most of the time they are brown on appearance. Cut section are brown. That's why we call it as brown tumors of the kidney. And not only that, you see the extensive areas of hemorrhage and necrosis. So always we see hemorrhage and necrosis extensively in the renal cell carcinomas. So we use the word variegated appearance for the renal cell carcinomas. Because of the extensive areas of hemorrhage and necrosis, we will use the word the variegated appearance of the cut section for the renal cell carcinomas. What is most important on cut section is, again, you have to look for the renal vein invasion. Remember, renal cell carcinoma is again an exception to the rules of malignancies. So we always tell renal carcinomas will spread through the lymphatic route, right? But here renal cell carcinoma is an exception. It spreads through the renal vein. So multiple sections we will give from the renal vein. If at all renal vein invasion is seen, then it is going out of a kidney. It is going metastasizing. So it comes to the renal vein, it goes to the inferior vena cava. That way it can even enter into the right chamber of the heart. So it's something like a snake-like fashion. It goes even into the right chamber of the heart. So that is how the renal cell carcinomas will spread. Even they can show direct spread to the Bowman's capsule that will be there over the kidney. So renal capsule also can be totally get adherent because of the infiltrative tumor. What is the classical on the microscopic appearance is the clear cells. Plenty of clear cells you see here. Viable nephrons can be there in between. So higher magnification of this cell. Yes. So clear cells. That's why the name clear cell renal cell carcinoma. So it can be slightly granular and eosinophilic, something like this. But you see most of the cells are having clear cytoplasm. So they have very much well distinct cell membrane, and the nucleus is center, not much actually pleomorphism, and extensive areas of hemorrhage and necrosis you will see also under microscope. Yes, that's the clear cell renal cell carcinoma. Let us have a second variant, papillary renal cell carcinoma. So it's again microscopy word. Papillary structures, if you see, it is a papillary carcinoma of the thyroid. Papillary carcinoma of the kidney. 10 to 15% of the renal cell carcinomas are papillary RCCs. Papillary growth pattern will be there on microscopic examination. Trisomy syndromes like especially 7, 16 and 17, they are the one who will have a papillary RCC. Loss of Y chromosomes in males also can cause the onset of a papillary RCC. Have a look at the microscopic appearance. So they can have a cystic change and they can have a plenty of accumulation of the they can have a plenty of accumulation of the macrophages, cyst macrophages, and this is how the papillary structures are seen. So this papillary renal cell carcinoma is mainly because of the microscopic presence of the papillary fronts. ChromophobeRCC, it is constituted around 5% of the RCC. It's quite rare. What is the interesting point about chromophobeRCCs? It contains eosinophilic cytoplasm and very prominent thick cell membranes. So we call these cells as plant cells, and there will be a halo around the nucleus, perinuclear clear halo will be there. Multiple chromosomal losses will occur, so hypodiploidy is very common, and origin is intercalated disc of the collecting duct. So especially it is the cortical portion of the collecting ducts that will give rise to the chromophobeRCC. It is having excellent prognosis. Yes, have a look at these plant cells. So these are nothing but chromophobeRCC, very thick cell membrane. So each cell are separated by presence of very thick cell membrane. The intense eosinophilic granular cytoplasm. So this is all contributed for the presence of excessive amount of mitochondria in these cells. So there is a lot of variation in the cell size and shape. So this variation will not be there in the oncocytoma. Oncocytoma also will have a pink granular eosinophilic cytoplasm like this, but the cells will be more of uniform in the oncocytoma. They will not show pleomorphism like this, and the cell membrane will not be so thick in the oncocytoma. Oncocytoma is a benign tumor, so malignant tumor is the chromophobeRCC, where you will see thick cell membrane, cytoplasmic eosinophilic granules. So, and there is a mild amount of pleomorphism of the cells. So this is classical appearance of the chromophobeRCC. The rare of the rare renal cell carcinoma is the collecting duct carcinomas arises from the medullary portion, the medullary collecting duct of the tubules, or you can call it as duct of Bellini, can give rise to the collecting duct carcinomas. Around 1% of the RCC are collecting duct carcinomas. Multiple chromosomal losses and deletions will be seen in these cases. Histologically, what you will see is the nest of cells with a prominent fibrotic stroma, and most of the time it is the medullary location. Yes, we will see what are the clinical features, how to identify these renal cell carcinomas. The classic triad is hematuria. It is so called as painless hematuria. Patient will have a hematuria, but he will not complain pain. Painful hematuria you will see in the kidney stones. So patient will have a renal colic, and on examination there will be a hematuria. But here painless hematuria. Along with that, patient will have a costovertebral pain. So you have to press in the kidney renal angle on the back. So patient will experience a pain. Then rarely you will see the palpable mass. The kidney mass, the tumor mass can be even palpable if you palpate the patient. So this classical triad is seen only in 10% of the cases. That you have to remember, not in all the cases. Hematuria will be there. That's the most common clinical feature. Around 60% of the patient will have hematuria. Palpable mass will be seen around 45% of the cases. There will be a renal pain at the costovertebral angle. That is a renal pain will be there in 40% of the cases. Patient can have associated fever, malaise, weakness, and even weight loss. Most importantly, they are very much prone for development of the paraneoplastic syndrome. Sometimes it could be radiological incidental finding of the RCCs. So remember paraneoplastic syndrome. Which paraneoplastic syndrome is very common with RCC? So you have to remember polycythemia, because the renal cell carcinomas, there will be excessive amount of production of the erythropoietin. That's the one which will induce, or even erythropoietin like substances will be produced in excessive quantity in renal cell carcinomas. That's the reason why hemoglobin will shoot up. So hemoglobin will be raised in these patients, so they will have a secondary polycythemia. There can be associated hypercalcemia, there can be even hypertension can be there in these patients, because again renin will be secreted. Sometimes they can even have a Cushing syndromes. So various paraneoplastic syndromes are described, and sometimes rarely feminization and even masculinization. So most important is the polycythemia, secondary polycythemia there within renal cell carcinomas. Yes, what is the mode of spread of a renal cell carcinoma? Remember, it is known for highly metastatic potential. Renal vein invasion is most important. You have to remember, it can directly spread through the renal capsule, and it can even infiltrate the adjacent adrenal gland, even the around the kidney, whatever the lymph nodes are there, they can also be get involved. But most importantly, it is the renal vein invasion. It can even go to the systemic circulation, to the lungs, especially to the adrenal gland, and even to the brain also. It can go to the any organ for that matter, even to the bones. So 5-year survival depends actually on the metastatic stages of whether it is totally limited to the kidney or already the tumor has metastasized. If there is no metastasis, the prognosis is good. Overall, around 40% of the cases will live for 5 years. Most of the time, the treatment of choice for renal cell carcinoma is the nephrectomy, and followed by chemotherapy and radiotherapy. So nephrectomy specimens are very beautiful specimens in these renal cell carcinomas. So whenever we have a cases of renal cell carcinomas, we will not much distort the specimens. We will take as many bits as possible to us, and remaining half of the specimen we mount neatly in the for the museum purpose to teach for the students. So we will take carefully, we take these sections from the renal vein to look for the metastasis of the tumor. Very important tumor in the pediatric population, very common tumor. Most malignant tumor again in the pediatric childhood is the Wilms tumor. Other name, nephroblastoma. Yes, it is the most common kidney tumor in the pediatric population, and it is also known as triphasic tumor. So here you can see that it is composed of epithelial component and the mesenchymal component, right? So there can be stromal component, blastomal component. So triphasic, epithelial, blastomal and mesenchymal. Thus three altogether we add it as triphasic tumor, but proportion of all the three can vary. So in this case it is predominantly epithelial. You can see that there is a abortive tubules are formed. So sometimes mesenchymal component may be more. In other cases the blastomal component may be more. So it is totally a combination of three components. So that's why we call it as triphasic tumor. So it's all due to the Wilms tumor gene mutation, WT1 gene mutation, and usually parents will bring their kids with a complaint of per abdominal mass. So once you examine, and you can come to know that patient is having kidney tumor, the child is having kidney tumor. If you investigate further, you will come to know that it is a Wilms tumor. So this is abortive tubule. You see that the tubules and abortive glomeruli, abortive tubule, abortive glomeruli are formed here. This is a mesenchymal component. That's a Wilms tumor, responds very well for the chemotherapy and radiotherapy. Most of the time it's a nephrectomy they will do. Sometimes it responds very much well for the chemotherapy. So prognosis is very good for Wilms tumor provided you have treated it early. Otherwise it's again known for the bad prognosis. Urinary bladder carcinomas, again the rare tumors of the the adults. Peak age is in the 40 to 60 years of age. More common in the males, male to female ratio almost 3:1. 90% of these urinary bladder tumors are the transitional cell carcinomas. So we also use the word urothelial carcinomas because it is a transitional lining that will be there in these bladder tumors. So this is a transitional epithelium. Normally you will see up to 7 layers, but here more than 7 layers of cells are seen, and the cells are showing pleomorphism, mitotic activity. All those features will contribute for the urothelial carcinomas. So this is how classically the transitional carcinoma will appear. So most of the time the urinary bladder carcinomas are diagnosed under cystoscopic examination. So cystoscopically they can be flat, or they can be exophatic, or they can be infiltrative tumors. Once you do the cystoscopic examination, you will come to know that patient is having a tumor in the urinary bladder. So take a small biopsy, it proves that there is a transitional carcinomas. Then you can go for further treatment. So that's urinary bladder carcinomas. Sometimes they can be due to the urinary calculi, bladder calculi can cause even squamous cell carcinomas can arise. Rarely worm infestations like cystosoma hematobium that can also cause the bladder carcinomas. Rarely even smoking also very important risk factors. Drugs like cyclophosphamide can cause hemorrhagic cystitis that can also contribute for the formation of the urinary bladder carcinomas. So that's about urinary bladder carcinomas. So read about renal cell carcinomas, very interesting topic, types of renal cell carcinomas, how it spreads, and what are the genes that are getting mutated, and what is most important is the cell of origin of the renal cell carcinomas, and also about the paraneoplastic syndromes associated with the renal cell carcinomas. Thank you.